Good evening, everyone. We welcome you all to OrthoTV online original webinar series. Today, we have with us a very senior orthopedic surgeon from Ahmedabad. And we also have on the panel with me, Dr. Salim Patel, who's a consultant arthroplasty and orthopedic surgeon from Mumbai. So over to you, Dr. Salim, to introduce today's speaker and topic.
Yeah, thanks, Neeraj. Good evening to all our viewers. Welcome to this OrthoTV Arthroplasty webinar series. Today, we have a very excellent, respected speaker from Ahmedabad, Dr. Dipak Dave. He's a senior orthopedic surgeon with over 32 years of experience, a director at the Department of Orthopaedics at the HCG Hospital, Ahmedabad, a senior consultant in the Department of Orthopaedics at the Sterling Hospital. He's been the chief of the AOA, that is the Ahmedabad Orthopaedic Associates, and has done fellowships in arthroplasty in various countries like Australia, USA, and Singapore. With this, I hand over the session to Dr. Dipak Dave, sir, who's going to talk about a very interesting topic regarding THR surgery. Over to you, sir.
Good evening, friends. The topic which I have selected is concept of functional safe zone and patient-specific anteversion in the THR surgery. Ensuring the optimal component positioning during THR surgery is a complex problem, but it is necessary because we want to prevent the dislocation, we want to reduce the impingement and reduce the wear. And for this, your component positioning has to be optimal. What we have been taught so far about Lewinnek safe zone. In 1978, Lewinnek told us that we should put our acetabulum in 15 degree plus minus 10 anteversion, and the inclination of the acetabulum should be 40 degree plus minus 10 degree. This article has been cited in more than 2,000 publications in English language. In 1978, he said that if we put our acetabular component in this angle and inclination, it is going to be the safe zone and it will prevent the dislocation. This was in 1978, but mind well, it was in a coronal plane on a standard pelvic X-ray. He suggested us this thing. We have all done this. We have put our cup in a safe zone of Lewinnek and anatomically aligned components we have seen on X-ray, but still it dislocates. Lewinnek safe zone has not provided reproducible guide to avoid the mechanical complications. And the placement of the cup within this safe zone does not always result in the reduction of the dislocation rate. Or at the same time, as I said, like impingement in a ceramic joint, we heard this squeaking. Like here you can see in this video, this sound of squeaking is because of impingement or early wear. In a nicely looking placed component, it just worn out in 5 years. Maybe it is because of improper placement and leading to early wear. So to avoid this, we need to understand the three players in the game, the femur and acetabulum. But there's a third player, spinopelvic unit. Now, set goals for the component placement do not reflect the variation in morphology and also do not reflect the spinopelvic mobility. We all know that the natural femur in our own body has got anteversion, which is about 8 to 15 degree. But there are lots of papers which suggest that there is a lot of variation in the morphology, and that variation can be minus 20 to 50 degree. And in cases of osteoarthritis, actually these are the conditions where we do the THR. The variation is even bigger, and the average anteversion can be more with a wide range of variation. And lots of paper which has also suggested that in a dysplastic developmental dysplasia, secondary OA, the femoral anteversion range can be from 2 to 80 degree. Now what happens when we do the THR? In a cemented stem, the anteversion of the stem can be surgeon guided. We have an option available. We can choose the anteversion, we can rotate the stem and try to select the anteversion what we want. But in the uncemented stem, what we are achieving is a stable press fit. And this is achieved based on the highly variable geometry of the femoral shaft, which is not in our hand, because that geometry can be variable. And to achieve that press fit stem, you have to accept the way the femoral stem goes in uncemented. Hence, the adjustment of the version in the conventional uncemented stem is limited or sometimes impossible. You cannot change because your stem will automatically go into the same direction which your canal will allow. And you have to accept that whatever you get. Like here you can see the press fit was achieved, a good stable stem, but the anteversion was 15 degree. A second condition where we achieved a good press fit stem on a trial, but the neutral anteversion of 0 degree. A third condition where the retroversion was there, but the stem was fit, a press fit, and it went into that direction only. And in another condition, there was excessive anteversion, which is more than 25 degree. So this is not in our hand. Proximal femoral anatomy and morphology will decide the femoral anteversion on table. And there is very little margin of correction in uncemented system, which is a common. All of us are routinely doing more uncemented hips now. And we have to accept the version which morphology gives us, which is inbuilt. Same with acetabulum. There is normal anteversion of 15 to 20 degree, but again in acetabulum also, there is wide variation in female and male, and you can get the different anteversion. Again, in a special conditions like DDH, slip capital femoral epiphysis, in revision cases, or with the spine problems, the anteversion of the acetabulum is also altered. Now, what we always see, we try to put our cup parallel to tal, and we hope and feel that it is going to be a proper anteversion, which is the case in most of the time. But as we know, parallel to tal, hugging the tal does not indicate the anteverted position of the cup. It just helps to put in anatomical position. Now, if your acetabulum itself is not properly anteverted, either it's a possiverted, retroverted, or more anteverted, your tal will accordingly change, and your cup placement will also be changed. And there are papers which suggest that tal anatomical landmark, is it reliable to orient the cup in primary total hip arthroplasty only considering the tal? The reason, there is another paper that also suggests that is tal a reliable guide for aligning the cup anteversion in total arthroplasty? And what is the conclusion? They say that tal should be used cautiously in all the cases because there is a risk of cup malposition. The tal anteversion has a large individual variation because your acetabulum has got large variation available, and because the tal anteversion can be outside the safety zone of cup anteversion. So you have to keep in mind how your acetabular cup is oriented. Accordingly, your tal will be oriented. So you have to be careful about this when you put the cup placement. Here, there is a neutral anteverted acetabulum component and retroverted acetabulum component. All the three components are parallel to tal, but because of the natural variation in the orientation and anteversion of the acetabulum itself, your cup position is going to get changed. This you need to keep in mind. So proximal femoral anatomy and acetabulum anatomy can vary in so many conditions. Universally applicable implant orientation guidelines cannot be useful in so many conditions. You cannot always put that cup inclination is 40 degree, anteversion is 10 degree. No, it's not possible. And therefore, the concept of combined anteversion came, because with this amount of variability, it is imperative to consider the anteversion of both acetabulum and femur as a single phenomenon. Now, cup and stem should be oriented relative to each other. So it's a combined, both femur and acetabulum orientation has to be matching each other. The component placement should be in such a order so you achieve the highest safety against the impingement. Now, the acetabular Lewinnek safe zone of 15 to 20 degree anteversion is not acceptable. It will not give you a proper combined anteversion. So in a low anteverted stem, you will have to increase your anteversion of the cup and the vice versa. This concept was given by Larry Dorr. And what he said, that you do the femur first. First assess what type of anteversion you are going to get in your femur. Decide that. Is it going to be normal anteversion, the retroversion, slightly hyper anteversion? Depend on that, you compensate this into the acetabulum. If the stem placement is in neutral to retro, then you can compensate that in acetabulum. This was a combined anteversion concept, which later on, number of other authors also gave us a figure that you should keep this in mind. Even Ranawat, he suggested an intraoperative test known as coplanar test, where on table you can decide and see that 20 to 30 degree in a man and about 45 degree in the women. If you get that angle and how to measure that, he is very nicely given in his paper. And on table, you can do this in a certain position, bringing the acetabulum and femoral head against each other, and then measuring this angle and make sure that your coplanar, which is combined anteversion of the femur and acetabulum, is giving you a good positioning. Till now, that that even your cup placement is in a Lewinnek safe zone, there is still dislocation. So there is something else to this. And the Larry Dorr concept of the functional safe zone, what it says, cup inclination and anteversion obtained at the surgery does not stay at the same angle in functional activities such as standing and sitting. You are doing surgery in a supine position, patient is going to get up, sit, walk, climb. In these positions, the acetabular cup is not remaining static because it changes with the body movements. And this change in the cup position with your postural change or the body movement is termed as functional cup position. And if your cup position is stable in all functional activities, naturally it will be very stable, and your component and the cup is a proper position. It will not dislocate, and it is in a functional safe zone. Now, how to keep this in mind? What he said, that functional safe zone is superior to Lewinnek safe zone for total hip replacement. So this is a new thing which he has said. And he said that Lewinnek safe zone is not always predictive of stability, which you've already seen. Enter the last player, the spinopelvic relation. So what this has got to do with your cup placement, your anteversion, your movements, your functional activities. We all know that spine, pelvis, and hip, they move in coordination to balance the trunk above the pelvis. Now, when you are standing, there is some degree of lordosis during standing. the pelvis is tilted forward. There is a lumbar lordosis and hip extension as shown in this figure. Remember, lordosis is there and pelvis is tilted forward. Hip is in extension. In this position of standing, the acetabulum anteversion always decreases. The anteversion is less in this standing position. But when you sit and change the position, the lumbar spine becomes straight from lordosis, the pelvis tilts backwards, there is a less lordosis, hip flexes. So this is the normal change which occurs when you are sitting. And in this position, the acetabulum anteversion increases. This is happening in a normal patient during normal activities of standing and sitting, as shown in this figure. Now, so when person goes from standing to sitting, the spine grows from less lordosis, from lordosis to less lordosis. Pelvis moves from forward tilted to the backward tilted. Acetabulum moves from less anteverted to more anteverted. And this is called biological opening of acetabulum. Remember, to accommodate hip flexion and internal rotation, when you sit, your acetabulum opening naturally is more. So there is more anteversion, which is known as biological opening of the acetabulum. Now, lumbosacral mobility is critical for this natural change. If spine is not balanced or spinopelvic fusion is there, then this compensatory spine and pelvic dynamics are going to get changed. Ultimately, it will change the hip stability. Remember, if you have a fused spine or an imbalanced spine, your movements is going to change, which will have bearing on anteversion of the acetabulum, which is related to spinopelvic junction mobility. As I said, in sitting, when you sit, the acetabulum anteversion increases more, which is not going to happen because of the fusion. And way back in 1985, Coventry reported that surgical spinal fusion leading to dislocation in operated THR. This was reported at that time. So if you don't consider spinopelvic mobility and flexibility, you are doomed to cause impingement, dislocation, and wear. The elephant is in the room. We need to address this. And what is that? It is sagittal pelvic tilt adjusted anteversion. This concept is slightly difficult to understand, but it's very important. And it tells us how, it gives us knowledge of how cup position changes during postural changes obtained by assessing sagittal mobility. And this is assessed by lateral standing and sitting, spine, pelvis, hip x-ray. You can see here, spine, pelvis, and hip x-rays in standing and in sitting. The lateral views have been taken. And on this, then we have to understand that we are doing this only in standing and sitting. Supine, we are not considering because there is hardly any change in the supine and standing. So we take x-rays like this and do the various parameters suggested in these slides, like sacral slope, pelvic tilt, pelvic incidences, lumbar lordosis. I don't want to go into the too much details of this, but these are very simple measurements which you can take on these x-rays. And by taking the values, you can understand the sacral slope decreases from standing to sitting position. Pelvic incidences, they remain the same. So equation is pelvic incidence is equal to sacral slope plus pelvic tilt. So if sacral slope decreases, the pelvic tilt increases, and the vice versa. How to do this measurement? It is very clearly shown in these slides. And if you do these angles and measure, then you will be able to find the movements in the sagittal plane and what is the relation we'll be able to see. Again, lumbar lordosis. Now, lumbar lordosis and pelvic incidences has got an equation because it tells it about whether the spine is balanced or not balanced. whether the spine is imbalanced or not is measured on these lumbar lordosis and pelvic incidences figures. And if it's 10 degree or less, then the spine is balanced. If it's more, then the spine is not balanced. So like this, you can get the figures, draw sacral slope, pelvic tilt, and the pelvic incidences on a sitting X-ray and on the standing X-rays, and try to find it out what happens. So in standing to sitting, again I repeat, the pelvic incidences remains the same, the pelvic tilt increases, the sacral slope decreases, the cranial pelvis tilts backward, and acetabular anteversion increases 15.6 degree. So with 1 degree change in the PT, that is a pelvic tilt, there would be about 0.8 degree change in the acetabular anteversion. How this comes knowledge in our practice. So if your spine is not balanced, or if it's kyphotic or lordotic, or if your pelvis is fixed or rigid, then this movement, the natural movement of changes of anteversion in sitting and standing is not going to happen. So how to find out the odd ones? We have to find out by these X-rays, measure these things which I have said, and try to find out from the sacral slope whether your pelvis is rigid, flexible, or hypermobile. And with lumbar lordosis and pelvic incidences measurement, try to find out whether the spine is balanced or unbalanced. And then you have these 4 categories: flexible pelvis with balanced spine, which is normal; flexible pelvis with unbalanced spine; rigid pelvis with balanced spine; or rigid pelvis with unbalanced spine. In these 4 clinical conditions, you have to find out what changes you need to do in your component placement when you do the surgery. The first and the foremost, flexible pelvis, balanced spine, which is normal. So in this, you can put your cup in a normal Lewinnek safe zone, which is 5 to 25 degree, because there is no changes there. But when the spine, the pelvis is rigid and the spine is balanced, like which is seen in large patients of degenerative spine, lumbosacral fusion. Now, here, the biological opening will not happen naturally due to rigidity. Understand, the pelvis is rigid. Because the pelvis is rigid, when you are sit down, your acetabular anteversion naturally increases. This is not going to happen because of the rigid pelvis. And because of that, there are chances of posterior dislocation and impingement. Here, you have to increase anteversion while placing the cup to compensate for relative loss in sitting. I'm again repeating. Normally, when you sit down, the anteversion increases. Here, the pelvis is rigid. It will not allow the anteversion to have more opening, and because it's a rigid and fixed. Therefore, you have to increase your anteversion to compensate for that. Normal arc in standing. So you have to be careful about that. But make sure that you do not increase anteversion too much, because the problem is happening in the sitting position. In standing, the patient is still normal because of the balanced spine. So you have to just put the cup in a higher zone limit, about 15 to 25 degree, to provide you the best range of movement in both standing and sitting. Again, when a flexible pelvis is there, but the spine is not balanced. Suppose you have a kyphosis, right, or a neuromuscular problem. Because of this kyphosis, to compensate the sagittal balance in standing, there is increased pelvic extension, and there is always increased acetabular anteversion. Here, in the standing position, your anteversion is already increased. Remember, normally in the sitting position, the anteversion increases. But to compensate the unbalanced spine or the kyphosis, the acetabular anteversion is always increased in a standing position. This will further increase when you move, because that's a natural thing. So in that condition, you will have to reduce your anteversion when you put the cup placement. So these are the practical things which you need to keep in mind when you are doing the surgery. Make sure the patient has got spine problem or not. Suppose it's a rigid pelvis and unbalanced spine, the worst scenario. You have to be very careful, because you have to make sure that there is no compensatory change in the pelvis with the change in the position. In these cases, you have to make sure whether you are going to do the spine first or the hip first. Because spine realignment surgery to make spine balance and then treat it as R&B, like rigid and balanced. Because as I said, there are papers which have suggested that without balanced spine, if you do the THA and subsequently the spine surgery may require revision of acetabular component to accommodate the pelvic reorientation following spine realignment. Like it's a fixed and a rigid pelvis, you have to make sure whether it is fixed in a extension or if fixed in a flexion, as shown in these figures. If it's in extension fixed, you have to reduce anteversion. If it's in flexion, you have to increase the anteversion if you are doing the hip first. So Lewinnek safe zone cup position was in coronal in AP plane in the AP film. Functional safe zone says that lateral spinopelvic hip X-rays in dynamic position and assess the sagittal mobility, which is very important thing. You cannot compare this with the coronal plane. Pre and post-operative sagittal plane sitting and standing X-rays will give idea on how cup position changes. Last slides. Can we predict dislocation after surgery? You have taken all the care. You have understood that there is a spine problem, the fixed rigid pelvis. You have taken into consideration the morphology and everything. And after that, you have put your cup and femoral component in such a position that you are happy. But late dislocation following total hip arthroplasty, spinopelvic imbalance is a causative factor. And there's a paper which suggests that you can predict that these THRs are likely to dislocate. So that's a very important point. And there are different measures. I don't want to go into the technical details of that, but like sacral slope, pelvifemoral angle, anti-inclination, and combined sagittal index, which are not very difficult. You can measure this in a routine practice, and with this, you can find it out what is the standing and sitting combined sagittal index range. And if you're out of that, then probably you're likely to dislocate. So these are the cases which suggest you that by this measurement, you can predict that after 1 year, your hip is likely to dislocate either in a sitting position or in a standing position, anterior dislocation or a posterior dislocation. That can be predicted also. And if you are finding it difficult, then we have now apps available where you can put the figures by drawing these X-rays, measurements, and calculate. And it gives us an idea whether you have to change your anteversion or you don't have to change the anteversion. And with this app, you can also be fairly accurate on table. The take-home message is the pre-op clinical evaluation of patient, including spine examination, is very important. And in those cases selected where you have some problem, dysplastic hip, other problems, do the sitting and standing lateral X-rays. It's a simple guide and you can get good measurements and understand how to put the component positioning. You aim the implant position in a functional safe zone, not a Lewinnek safe zone, not a combined safe zone, functional safe zone, because it is affecting your daily routine movements. So impingement-free functional positioning to reduce the rate of dislocation is very important. That's what you need to keep in mind. Is it a death of the Lewinnek safe zone and dawn of new functional safe zone? What 1978 Lewinnek told us, now what Leridor says us, there is a change and it does not require any change in the operative technique. It simply requires more attention to the functional motion of the pelvis and spine for determination of the cup inclination and femoral anteversion at the time of surgery. Thank you.
Excellent, sir. Excellent presentation and very clear facts about Lewinnek as well as the functional safe zone. Sir, I had one basic question after listening to your talk. Sir, can we conclude that one of the best predictors for hips falling outside the functional zone, either preoperative or postoperative, would be the femoral mobility and not the sagittal cup position? What are your comments on that, sir?
No, you have to take both into consideration. See, because spine, pelvis, and hip, the femur, they all work in one unit. You cannot have one component independently working. It has to be combined. So I think what the evolution is saying us, that there was a safe zone of Lewinnek where he told that you put the cup like this.
Right.
Then Larry Dorr came and he told us, no, do the femur first, see how much you are getting in femur, try to adjust in cup and do a combine. After that, he himself came. He said, oh, but what is happening? If there is a spinopelvic fusion or imbalanced spine, because this is all a one unit. That's for in a lateral X-ray, they take spine, pelvis, and hip in one film, and they try to see that. So he said that during our natural movements, normal movements, when you are standing and sitting, the position of the acetabulum, the anteversion normally changes in you and me. And what they are saying that when you put the artificial cup, that is also going to get changed.
Absolutely.
So your cup placement has to be in a functional safe zone. That is very important. So that in the movement, it remains in a proper position and it does not dislocate.
Perfect. Great. Secondly, sir, what would be your stay in a case of ankylosing spondylitis? So how would you assess the cup placement there?
No, again, as I said, you have to find it out. There are 4 various conditions. In ankylosing spine, is your spine fused?
Right.
And the pelvis is mobile?
Right.
Or do you have a balanced spine but fixed pelvis?
Right.
Or you have both, where the spine is not balanced and the pelvis also rigid. So we have given in the slides. If they just read it again and again, they will be able to understand what conditions you are dealing with. Suppose it's a worst scenario where the hip is fused, spine is unbalanced. Then you decide what you want to do first. Do you want to operate the spine first or the hip first? If you wanted to operate the hip first, then you decide, is your hip fused in extension or they are fused in flexion? Accordingly, you have to change your anteversion. If the spine is not balanced, they suggest that you make the spine balance, because after that, sometimes your chances of dislocation will increase. So there are various clinical subsets, conditions, 4 possibilities, right? You have to see where you fit in.
Right. So in these cases, sir, the app will be very useful, according to you.
Yes, it's a simple thing. See what happens, preoperative planning. Every good senior surgeons will always tell you that you should do the planning, you should do the draw, but people are very busy. They don't concentrate except in teaching institutes or some good centers where they are very academically oriented. We are not interested in drawing these figures and measurements and other things, right? Probably we try to give it to junior people and tell them to do that. But the idea is that you understand the philosophy, that all the time you put your cup in one position may not serve the purpose. That's what the whole thing is. And the apps are available. But again, for app, you have to put the figures in.
Put the figures
in, you have to draw. You have to measure and then put that into that app. So ultimately, you will have to do that exercise.
Right. Templating is important.
Correct.
Right. Yeah, Neeraj, over to you.
So, sir, this is very interesting to me. I am basically a big fan of apps, as I take a lot of lectures on apps. So this may be one of the additions of the app. So this app is available for iPhone and Android both?
Yes, both.
Both, okay. And what is the investigation do we need to put in? Do we need to take the measurements ourselves, or the X-ray guy can take it?
I tell you one thing. Suppose I am doing a THR. Everybody is doing THR. What we normally take, we take a pelvis hip X-rays, upper femur, we try to take a femur lateral view.
Hmm.
So there is a bowing or not. These are the normal exercises.
Yes.
Sometimes we take CT scan to see the bone stock, the bone defect in the, especially in the acetabulum. Here what they are saying, that add the lateral X-ray of spine, pelvis and femur, or the hip, lateral X-ray in standing and sitting. It's possible. We have shown you lot many X-rays, right? And by taking this, you will consider the sagittal mobility and sagittal balance. That is the plane which was missing by Lewinnek. He was only telling us in coronal plane, only one side, one plane, right? It is not the same thing. So addition to the normal X-rays and CT scan, what we need to do is take the lateral view in standing and sitting for the sagittal balance. That's the additional thing which you have to do.
And sir, see, many spine surgeons, what they say is that if you have a stenosis and you have to undergo a THR or TKR, you should first get your spine treated and then get your THR and TKR done. So what is your take on that?
Yeah, I think there are lots of papers for that. As I said, there is a spine hip syndrome or a hip spine syndrome or a knee spine syndrome where you have to take this into consideration. I've shown you one photograph where patient's laminectomy has been done and patient has got severe arthritis of the hip. In this lecture only, there is one X-ray. So patient's already been operated for that. Again, as I said, there are in Coventry, in way back 1985, he said that he did the THR. Then the patient underwent the spinal fusion and the THR dislocated. This is what the whole philosophy is, that you have to take into consideration. If you're knowing that this patient has got a problem, either you do your spine first, make it balanced, or you put your cup placement in such a way, keeping in your mind your spine fusion or lordosis. That's what you have to keep in mind. Or sometimes this also tells you that you have a choice of using an implant like dual mobility, because these are the patients which are likely to dislocate. So to prevent that, you can use the dual mobility. See, the last paper which he suggests that after doing the surgery, there are measurements which tells us whether this is going to dislocate or not. And suppose if I find, oh, my hip is going to dislocate after 1 year, then it's a worry, but it's a lesson, it's a learning. So you know that in those sort of cases, or where there are additional problems of spinopelvic mobility, you can use a dual mobility type of implant where the dislocation rate will be less.
Okay.
Perfect.
So, but sir, my question was a little different. Should I do the spine surgery first, the THR first, or the TKR first? All three are required.
This needs clinical evaluation.
Okay.
May I tell you one thing? People come to us, I cannot walk. Now they are not knowing, Sab, leg mein pain hai. I have pain in the legs. What do you mean by leg pain? Are you talking about knee? Are you talking about buttocks? Whole legs? We have to make them understand that the pain coming from the spine is different from the knee pain or a hip pain. Here, there is a lot of clinical importance. You listen to the patient, your answer will come from him. After explaining him everything, that what pain is coming from where, he himself will tell you, नहीं साहब, मेरे को नहीं करना है, मुझे तो spine का ही problem है, आप जो बता रहे हैं, now I understand that my problem is because of the spine, because I'm getting the leg pain. Or he will say, no sir, my knee is bad. So you have to clinically evaluate depending on patient symptoms, clinical signs, presentation, and also at the same time, your investigations.
Okay. Okay. Thank you, sir. Thank you very much. Thank you for pointing out this new thing, which many of us may be not aware of in the current generation. Yeah. And there are many people who are doing primary THRs left, right, and center now. All the young people who have been trained 10 to 15 years later than me are mainly interested in arthroplasty.
Yeah, I think this is a slightly a new and topic, needs some more understanding, but it's a very interesting topic.
Interesting topic.
As I said, the last article of Larry Dorr, where he has said that you can predict that your hip is going to dislocate. Oh, that's a very learning
thing.
point
Absolutely,
to
absolutely.
know that you should be so careful so that you don't make mistake and your THR doesn't dislocate. So that's the whole idea. Or the wear or impingement. These are the two things which you need to prevent, and you can prevent by proper component position.
Yes,
absolutely.
Okay. Thank you very much, sir.
Fine.
We thank Dr. Dipak Dave for sparing his precious time and giving us this new technique and maybe opening up our eyes. As everybody says that ignorance is bliss and knowledge is fallacy. So many young arthroplasty surgeons will get to learn a lot of things from this new technique. And we thank our panelist, Dr. Salim Patel, for being there with us on the panel. So thank you, everyone, and good night.
Thank you. Good
night.
Thank you,
sir. Thank you. Thank you.